Continuing our conversation that we started earlier with a special report by Sylvia Chebet on HIV and AIDS, and in particular, why men aren't getting tested. I'll reintroduce my guests to you, beginning with my immediate right. MC Baridi is a student youth HIV prevention ambassador. Next to him is Dr. Christine Sadia, who is the national chairperson of the Kenya Medical Women's Association. To my left is Dr. Peter Cherotich. He is the head of the Department of Preventive and Promotive Health in the Ministry of Health. He's also the principal investigator for the partner notification study, which you saw in that report. And next to him is Roberta Bobby, who is a student. And you're all welcome to the program. Dr. Cherotich, I want to start with you. I mean, what led you to this dramatic study?
Thank you, Anne, and thank you for hosting us and to talk about this study and to talk about this program. First, just to say that it's not really a new thing what we're talking about. As far as HIV is concerned, and even many other infectious diseases, this is the way to do things, and it's been happening in Europe and in the US for many years, because the basic idea is that for any infectious disease, there's usually a pattern in which it spreads, and for HIV it's mainly through sexual contact. And therefore, for you to be able to control HIV, you really have to drill through that network. You have to identify first from somebody who is HIV infected, look to see who potentially that person may actually have infected, and then work through that process up to the time when you feel like you've really penetrated that network. So infectious diseases, by and large, you talk about TB, even Ebola now that is still live in the Congo. The way it's controlled is that once you get somebody who is suspected to be Ebola infected, then it is just prudent that you actually get to know any other person whom that person had been in contact with. So
this is the way to go.
This is the way to go, yes.
I know, even just in the run-up to airing this program, a lot of people were saying, but isn't that such an invasion of privacy, asking somebody who their previous, sexual partners have been, and going far enough to call these people and tell them, hey, you could have been exposed. What kind of feedback were you getting? Right.
And you're absolutely right. We've been concerned about that. And that's partly the reason why this approach has not been used before in Africa. It's been the standard practice, as said, in Europe and in the US, where people have been used to it and people have access to treatment. And one of the reasons we actually did the study is actually to find out, in Africa, is it acceptable here in Africa? Do people feel comfortable with it? Could there be unintended consequences, like you mentioned, invasion of privacy and families breaking up and dissolving? And that motivated us to do the study here in Africa, to demonstrate that doing this thing called partner notification in Africa is actually the way to go. It's safe, it's effective, and it doesn't harm anyone. And we're very, very privileged that we were able to demonstrate that the study is very effective in reaching out to people who are HIV infected, who can get to know the HIV status, but it's fairly safe, and we are happy about that.
Why are men not tested for HIV?
Right.
Why do they not accept to go for testing, rather?
Absolutely. I think Dr. Sadia would better speak to that, but I would...
But you're a man.
Yes, but I'm a man, yes.
So we may as well start there.
We may as well start there.
Right.
No, first is that we don't have as many opportunities as women to test for HIV. As you may know, the way our programs are designed, a lot of women test actually as a routine in antenatal clinics when they go for antenatal care, so they get exposed to HIV. But I think there's also a cultural element where men tend to seem that they are invisible and that they're unlikely to get sick or unlikely to get, HIV.
Because they're invisible?
That is probably a cultural thing. I mean, that is potentially there. I mean, I wouldn't say it's...
Yani virus haikuoni. Is that what you're saying?
That is the thing, yeah.
Wow.
So, I mean, but also, from a cultural perspective, particularly from African settings, men tend to give excuses that they are fairly busy and they are fending for their families, and therefore they don't really have time to like go to test and all that.
Interesting.
I mean, the question is still out there. I cannot speak authoritatively as to really why men are not coming out to test. What I can confirm to us is that on the other hand, women actually have greater opportunities to test, and that brings out the differentials.
What about you, MC Baridi?
About men?
Yeah.
Okay.
I know you've been tested, and we saw you being tested.
Yes. I work with most of youths across 47 counties, especially students, but if you ask men why they don't go to have HIV test, it's like we are strong. Shikilia. Because they feel like if my girlfriend goes and get tested and come and tell them I'm HIV negative, they feel they're safe. The other thing, if I have headache or malaria, I will not go to the hospital. I'll just go look for a paracetamol I take, and then I'll be better. So it's hard. There's nothing. We don't have that structure that push men to go for the health facility to get tested. Also, with the stigma that in the hospital or the facility, you want me to come and sit down with most of women, 60% of them, or some of them at the facility have babies, and then you want me to go line and then go to get tested, and I'm not sick. Maybe if Roberta, she's a student, maybe she came there, maybe she has some issues. Maybe if she's a woman, she's pregnant, but me, I'm not sick. Until a man becomes very sick that now you have to take this person to the hospital by force, that is the time now they can get tested. And also the other thing, that give men services at where they are. Most of men, some of them, if you go to rural areas, they are in Jengo, they are in motorbike. So people tend to think that I carry myself to the hospital to do the test. If you bring the service where we are, if you pitch those tents around the area, I'll be able to go because of peer pressure from other men around me. But if you want me to just walk to the facility, what am I going to do in the facility for the first place? And the other thing also, I was talking to some men yesterday, and they were like, how do I go to the VCT to the test? For what? And it's better I remain with my HIV without knowing, because they feel that when they go and get tested and realize that HIV, see, those are youths, the stigma because they have a lot of people that talk about it every time, that, hey, mimi kijipima nimepatikana positive, kuisha. So that stigma that comes around them when they discuss, it's taking them that I don't want to go for that VCT. So
you feel even now in 2018, when you've got you know, antiretrovirals, I mean the scientific progress in terms of managing the viral load is just, you know, it's at its best of all time, that stigma is still very much a real thing.
Stigma is still high.
Okay.
You know why stigma is still high? When the President Moi called HIV as a national disaster in 1980 something, the way HIV became in Kenya, it was with a bigger stigma. So nobody has sat down to rectify and correct. So it was like, you see the billboard, someone amekonda sana. So you feel like if anybody, HIV, they see, like, if you talk about cancer, most of people see cancer is far. Until cancer, the relative or somebody told you have a cancer. That's how young people or men look at HIV, because of the stigma also. Somebody will feel free with cancer, but not HIV. HIV is still far to them. That's why sometimes they use protection, they don't use protection. But the real problem is the stigma is still real. Very real, okay. Yeah.
Dr. Sadia, your insights?
Well, I would like to talk about the issue of stigma is real, but I think the health-seeking behavior of men is the issue, it's a cultural issue and need to be addressed. But it's not that they don't have spaces for testing. I think we have already developed quite a number of, since 1984, we have actually gone quite far, and their testing spaces are quite many. I think it is in the DNA of the men that they want to anonymously test, but at the same time, even disclosure. If we come to disclosure, so many men will test and they find that they are positive. But even disclosure, even when they know that their partners could have been protected, they still do not disclose. So there's something culturally about it, but there's also something in men-seeking behavior and risk-taking behavior. So I think that's where the problem is and where the disconnect is. And I think it's a gender issue, but it's also a cultural issue that we need to work around. I do not want to agree in this particular time that a young boy at this particular age should, with the prevention programs that we have, should still be thinking like when HIV was declared national disaster. There is a lot of information out there. There's a lot of myths and misconceptions that have been dispelled. And I think it is maybe, for me, an issue of whether it is just a denial. I think it's more of the denial and the stigma. So we need to work around the denial and the stigma. We need to look at a lot of disclosure programs that will help people. But when stigma fuels, when stigma is high, then you find that people do not test. You find that people do not accept to even have HIV disclosure and even go to tell their partners to protect them. So I guess women are the losers here, because you may find that a pool of men have a lot of infection which are not tested. They are not because what HIV testing and your knowledge of whether you are positive or negative, what it does is either reinforces you. When you are negative, you would like to remain negative. Therefore, your risk perception is already heightened, so you do not take risky behavior. But if you do not know, then you walk in the rampage. You think that you're safe, you perceive yourself as safe. And I think this is something that is a gender discussion that needs to go on, because men seems to be in the pool that continue to infect a lot of women, their partners. Maybe I don't say women alone, but their partners, because they carry a pool of virus that is not detected. So I guess testing becomes a critical element that we need to deal with.
Well, that's really food for thought. I mean, Roberta, you know, your age group, the 20s, are the high, as you know, seeing the highest new infection rates.
Yeah.
And this is happening, like I was saying earlier, at a time when you've got you know, the most information out there. You know what your ABCs are. You know there's pre and post exposure pills, all of that. Yeah. But still, with the most educated, if you like, lot, you're still the ones getting most infected. Why do you think that is?
It's because I'd attribute it to mostly what Baridi said and what the doctor said. People are afraid, but then again, they want to have fun. They don't really care about the repercussions, the consequences. And most people my age, of course I interact with most people my age. And I run a blog and I get a lot of feedback I write about relationships and sex, HIV, things to do with that. So I get feedback that people are really into having fun, that the afterthought comes much later. So it's not scary when you're in it, when you're doing this, when you're having unprotected sex, when you don't want to go get tested, when you know all these things. You've been in school, you have the internet, you have even friends of yours, you know people who suffered HIV. We really don't have an excuse to give, you know. But I don't know, I think people are not that scared. I'm not saying HIV is supposed to scare people, because then again that brings out the stigma, but I feel like you need to know where you stand with your status, and that's not where people my age's minds are. People just want to go with the wave, they want to follow, they want to jump on the bandwagon, they want to know what's happening where, so they can have fun. So it's a bit scary, and I think we need to sit down and start thinking back and start really focusing on taking care of ourselves.
And that's so interesting, because you know, in my generation, if you grew up in the 90s, then you grew up, you know, with some very thematic, you know, HIV and AIDS songs. You remember the movies that were sponsored by governments. It was frightening, and perhaps in some ways that did you know, aid a certain type of behavior. But it's quite interesting to hear you say that, you know, it's about, you know, the pursuit of fun. Do you think there is a feeling of, you know, kind of being, you know, the immortality kind of feeling that comes with you, that nothing can bring you down?
Something else is just what you also said. We have all this ARVs, we have medication, we have what. So people feel like they are going to be able to manage it. It's like, okay, so what if I get it? People are surviving, but they're not thinking they might be actually putting other people at risk. You know, it's not just you. If you are, like my mom tells me, if you're suffering, then you're suffering alone. It's okay. Even if it's just a cough, or even if it's just a small homa, you know. But then again, these are things that affect everyone. It's going to affect your family, your friends. Everyone is going to be affected. So people just need to start caring. That's what I feel. You know,
for you, Dr. Cherotich, from a research perspective, you know, how have things like, you know, ARVs, pre and post, you know, exposure drugs affected the way we view HIV and informed our lifestyles?
Thank you, Anne. I think for us to understand that, we'll have to go back to history. Now, in the United States, when ARVs first became available, that is in the late 90s, what we saw is that, of course, there was a sense of optimism. You know, people then were happy that there were new drugs and people would potentially then live longer. But what we saw was that there was a sort of an upshoot of what we call risk sexual behavior. People started using unprotected sex because they knew that there were ARVs, and we started seeing a lot of other bacterial sexually transmitted infections. So it could be possible that what happened in the US, this the level of complacency that happens when you have ARVs, when you no longer see, you know, people dying. Like when I started practicing as a doctor, you know, we would see a lot of patients coming in with HIV. There were no ARVs then, and people would come in and they would die, and there would be nothing that we would do. And there were a lot of funerals. So now you don't see like thin and haggard people. You don't go to many funerals, people living with HIV. So it could be possible that there is some level of complacency that is permeating into our society. HIV is becoming more and more abstract. It's not probably as real and as tangible as, you know, during our time. So that could be possible, that, you know, like Robert is saying, is that it could be influencing the way we are behaving, and also our sexual behaviors and the way we relate. That means, therefore, that I think we need to step up our efforts. We need to re-engineer our communication and our engagement.
But, you know, Dr. Sadia, is it true, though, that there is, as some may say it, in the complacency, no risk now? You're not, you know, is that a truth or a fallacy? That's a fallacy.
It's a fallacy in the sense that if you look at the segregate data by age categories, that you find that a certain age group that will work. Treatment, whether as prevention or treatment as treatment, would keep people longer. But among the age groups, the younger age group, let's talk between 10 and 24, that is not true, because they are also not accessing the treatment. The entry to treatment is testing. Only in Kenya, for example, about 15% of the age group between 10 and 15 have been tested. That is statistics that we have. If you look at that vis-a-vis even their knowledge about literacy on treatment as prevention, or HIV, or on treatment as something to keep you alive longer, to keep you in a chronic stage, that they don't have that perception. But what goes on with the treatment? What is it, the baggage that you have with treatment? Yes, it keeps you longer, but the inconveniences, they cannot take the inconveniences. For example, in schools, even those who are infected from their mothers, if they go to school, and that is now the bulk of the young people that are living with HIV. About 70% of the people living with HIV got it from their from mother to child transmission. What it happens that still the disclosure and the openness, the enabling environment to allow you to take treatment is still not there. So even those who have started on treatment, they do not adhere to treatment. So it's not working for a certain population. It's not working. Even just the burden of the initially when you start, the drug reaction and perhaps changing so that you get used to the drug, and then you become now you used to it and taking it daily, it is an inconvenience, and the young people do not adhere to that.
Do not
regime.
suffer that inconvenience.
Yes, even the keeping, even for, let's take home. Sometimes even parents do not allow their children, even if the child had got an adult, a teenager, has gone and tested and has been put on treatment. They come home with treatment. Mothers sometimes and parents keep on snoozing on their whatever to buy, and that has become a real issue. I deal with people every day that says we cannot keep our drugs, we keep on hiding because, and the enabling environment to allow you adhere to treatment for the young people is different. Maybe if it is somebody like myself who has already come to terms with it, and maybe my spouse has known if I have a spouse, but if even I'm living single, then I know it is my environment, I can control my school environment, university environment is very hostile for ARV treatment.
And so when one cannot keep up with the regimen, the drug regimen, then it's the drug's not going to work.
You are not reaching the optimum level where you either drug is preventive, you cannot infect, and you have not reached an optimum level where you are also protected, where you will not move from the HIV to AIDS.
So saying that there are drugs out there pre and post is not a safeguard.
It's not a guarantee.
It's not protection. Go ahead.
I think on behalf of the people that I've dealt with, negative and the positive ones, I always say that mostly tradition, I think, is the worst enemy on civilization, mostly in our Africa countries. And that's why if you see a lot of programs that it's about HIV, it's being developed by elderly people. They do a lot of the program, then they come down and then they want to implement them to young people. And that's why we are still struggling with this. And it's possible for us. If we go back to the ones who are taking medication, who are on treatment, who are in the facilities, some years back we had programs of, if you go to facility, there's a support group, which was being supported with different partners, that a young person can come and they discuss their own way, own issues, and come with the solutions. Those programs, most of them right now, they are not there. This young person who taking medication in the university, even the high school, coming back to take drugs, and they need something to motivate them. And the other thing, HIV is not an issue.
So mostly. Support groups are now missing?
Yes, support groups are missing in a big number. The other thing right now, since we start, like Blast has started engaging with NASCO for the last now 2 years. Right now we are doing, last year we went to around 23 counties in different universities to bring HIV testing at their school. And a large number of youths came to do the test. Right now we are planning to start again from 9 counties to go to the universities and make sure that we test. We have something called Campus Heart, where when you are tested, you're supposed to be put on treatment, a test and treat according to the NASCO. And then we have a support group that called Susichome CV, where if we're positive, we have a support group for the positive people, and they come discuss their own issues. Now, I want to say this, it's possible for us as a country, because even right now we are at USIU doing HIV testing to the student, this week, all of it. If we can have these young people to be put together in different places, negative or positive ones, and ask them, what do you think? So that we can have a table, we can have a desk for at least youth in at least some places where they can talk about their issues, because they need something to motivate them. When you want to discuss HIV with youth, you don't just come and ask somebody about HIV. That's why when you go and tell a youth, I'm from Ministry of Health, we have a tent there, we want you to go to test, they don't want to hear that. But when you come with something, maybe relationship, and start a discussion, most of people come out to talk about it.
Because much of it still is informed by lifestyle choices. Much of the exposure is informed by lifestyle. And I hear you, then they need to have the youth themselves drive that. You speak to your age group quite differently than you'd speak to mine and to the doctors here. As we're out of time, Dr. Cherotich, you know, the world is moving towards this zero new infections. They say Denmark might be the first country to record zero new infections. So where's Kenya right now?
I would say that Kenya, we are doing well, but not as much as we'd like. You know, not as well as we would like to do. Our HIV prevalence is about 6%. We are recording about 80,000 new infections every year. That is coming down. The biggest progress we've made, though, is in reducing transmission from mother to child, where we've dramatically come down. We do hope that we will actually be able to eliminate mother-to-child transmission well before 2030. But just coming back to what Baridi mentioned, it would be very useful, particularly when you have programs targeting the youth, like his programs, is to ensure that for every young person that you get to be HIV infected, that you actually use that person. First, of course, you make sure that that person gets access to HIV care. But then you use that person who is HIV infected to then lead you to actually identify more HIV infected. It is the most efficient way to do things, because again, sometimes testing indiscriminately, just going at random and testing people, will not really get you to really where you want to be. That is identifying as many people who are HIV infected and putting them on care. So
use the network.
Exactly, use the network approach, and you realize that through that you'll actually be able to identify maybe other young people or even other older people, men, women, and all that. So it's a very efficient strategy of using it. Right. And it's one of the things that we are encouraging as government, that it should be scaled up across the board, will actually enable us to achieve our elimination targets well before 2030.
Okay, we have just about a little over a minute to go, so very quickly, Doctor, what would you want the audience at home to know about HIV and the importance of testing and I suppose responsible living as well?
I think a lifestyle approach. We need to adopt a lifestyle approach, a life cycle approach, or a lifespan approach, where young people from a very early age, we know that if we leave you up to 10, it is already late. What programs do we have, age-appropriate programs that we are giving to ourselves, even to the old ones like myself, because right now HIV goes up to the age of 65. So in fact, it is increasing in other age brackets, like in homes, married couples, which used to be protective, are no longer protected. So I think we need to do more in terms of programming and disaggregating data. We don't have enough data to target the kind of behaviors, because people in their lifespan behave differently. Are we preparing people for the life as they develop through the spectrum of life, that when you are in this age group, this is what is likely to happen, and therefore we target our prevention program and also risk perception and even programs that we give people to actually look at their developmental or lifespan, where they will be. I think for me, that will be something. And also in the country, we need to do gender desegregated data, age desegregated data. And I want to talk about poverty. HIV within poverty and even treatment will be something that we will need to talk about later. But thank you very much for that thrown it out.
Thank you. Yeah. Roberta, what do you want your peers to know?
I'd want people to love themselves. Think about yourself. Think about the people around you, whether you have HIV or not. Just love yourself, protect the people around you. I think that's what you need to know. And if you're in SIU, come get tested. The whole week we're going to be there. And you can follow us on social media so you know where we're going to be as we progress.
MC Baridi, what do you tell men especially about getting tested?
It's not about MC Baridi or the government or blacks, it's about us as Kenyans. So we need to come out and push this. It's not about HIV positive people or negative people. It's about your life as Kenya. So if you want to know your status, kindly try your best to have that courage so that we can build this nation a better place, because health is wealth.